Good morning and welcome, everyone. Today is September 29th, 2021, and I'm pleased to call our ACIP meeting to order. Before we get started, I'm wondering if you can go to the next slide. I have one announcement. Today, I have the pleasure of introducing Dr. Melinda Wharton as our new Executive Secretary for the ACIP. As many of you know, Dr. Wharton has held many leadership roles over the years. A little bit of background about her. So she received her medical degree from Harvard Medical School, her MPH from Johns Hopkins, completed her training in internal medicine at the University of Michigan, and her ID training at Duke University Medical Center before coming to CDC as an EIS officer. She joined CDC's immunization program in 1992 and has had many, many roles central to ACIP since that time, including Director of the Immunization Services Division, Acting Director of the National Vaccine Program Office, Acting Director of the Immunization Safety Office at CDC, Deputy Director, as well as Acting Director of NCIRD. In her current role, Dr. Wharton is the Associate Director for Vaccine Policy and Clinical Partnerships at NCIRD. And I personally have appreciated her co-leadership with Lori Markowitz of the COVID-19 Vaccine Safety Technical Work Group over the past year, and that has taken a lot of time and dedication from the team. And this is what I knew about Melinda until yesterday. If you'll go click the next slide. Last night, I discovered something new about Melinda. She also loves to ride. She has logged in over 369 bike trips and over 3,000 miles as a cyclist. And so we are so grateful that Melinda agreed to be on this new ride with us at ACIP as the new exec sec. And I know that all of our ACIP members appreciate her willingness to serve and lead in this role. So I wanted to thank Melinda for her willingness to serve as our executive secretary. I also know that Dr. Cohn is listening to this and thinks she may have gotten off the hook, but I promise that at the October 20th to 21st ACIP meeting, we'll spend a little time together appreciating Amanda and her leadership of the ACIP and the important role that she has played in shaping national immunization policy during that time. For now, I will turn it over to Dr. Melinda Wharton to run through our announcements.
Thank you so much for that introduction, Dr. Lee. Good morning and welcome to the September 29th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members, and then from ex officio members and liaison representatives. We will stay on schedule per the meeting agenda, even if we're running early. Please disable your video. A profile picture is fine, just no live video. But please, we ask ACIP members to turn on their video during votes, but that actually is not relevant for this meeting because we don't have any votes scheduled. Next. Next slide, please. Well, I will go ahead. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period. The oral public comment will occur today at approximately 2:35 Eastern Time. To create a fair and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blinded lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using the docket number ID CDC 2021-0075. Information on the written public comment process including as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next, and with that, I return the microphone to Dr. Lee.
Thank you, Dr. Wharton. I will now take roll call, starting with the ACIP members and then the ex officio members and liaisons. For the ACIP members, please be forewarned that I may go out of order today and in future meetings. As a reminder, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. So today we're going to start with Dr. Long.
I'm sorry, did you say starting with Dr. Long?
I did, Dr. Long.
Okay, good morning. This is Sarah Long. I'm professor of pediatrics at Drexel University College of Medicine and a pediatric infectious disease doctor, and I have no conflict.
Thank you. Ms. McNally?
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Palin?
Good morning. This is Kathy Palin. I'm a professor of pediatrics and epidemiology at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflicts. Thank you.
Thank you. Dr. Sanchez?
Morning. This is Pablo Sanchez. I'm a professor of pediatrics at The Ohio State University and Nationwide Children's Hospital. I'm a neonatologist and pediatric infectious disease specialist, and I have no conflict. Thank you.
Thank you. Dr. Talbot?
Good morning. I am Kip Talbot. I'm an associate professor of medicine at Vanderbilt University Medical Center. I specialize in infectious diseases, and I have no conflicts.
Thank you. Dr. Alt?
Morning. My name is Kevin Alt, and I am a professor of obstetrics and gynecology at the University of Kansas School of Medicine in Kansas City, Kansas.
Thank you. Oh, do you have any conflicts?
Sorry, no conflict.
Thank you. Ms. Bata?
Good morning. This is Lynn Bata, and I am a clinical consultant for immunizations at the Minnesota Department of Health, and I have no conflicts.
Oh, sorry. Did you say you have conflicts or have no conflicts?
I have no conflicts.
Thank you. Dr. Bell?
Beth Bell, clinical professor, Department of Global Health, University of Washington. No conflicts.
Thank you. Dr. Brooks?
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in Los Angeles. No conflicts.
Thank you. Dr. Chen?
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health within the University of Maryland School of Medicine and Director of the Travel Medicine Practice. Thank you.
Thank you.
Oh, no conflicts. Sorry.
Oh, thank you. Thanks, Dr. Chen. Dr. Sinayas?
Good morning. I am Dr. Sybil Sinayas. I'm an internist and a pediatrician, Associate Professor of Medicine and Pediatrics at the Warren Alfred Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning. Matt Daly here. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Cotton?
Good morning. Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. No conflicts.
Thank you, Dr. Cotton. Dr. Lair?
Dr. Jamie Lair. I'm a family physician in private practice in Ithaca, New York, and I have no conflicts.
Thank you. And I am Grace Lee, Professor of Pediatrics, Stanford University School of Medicine, Associate CMO at Stanford Children's Health, and I have no conflicts. Terrific. All members are present, and we'll move on to our ex officio members and liaisons. And as a reminder, I will announce the organization name, and then please indicate if you are present and your first and last name. So Centers for Disease Control and Prevention.
Good morning, Sam Posner, CDC.
Good morning. Centers for Medicare and Medicaid Services.
Good morning, Mary Beth Hans for CMS.
Thank you. Food and Drug Administration.
Good morning, Doran Fink for FDA.
Thank you. Good morning. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, HRSA.
Thank you. Indian Health Service.
Good morning. This is Thomas Weiser for Indian Health Service.
Thank you. National Institute of Health.
Good morning, John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Morning. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. This is David Kim, OIDP.
Morning. We'll move on to our liaisons, the American Academy of Family Physicians.
Good morning, Dr. Pamela Rockwell, Professor of Family Medicine, University of Michigan Medical School.
Thank you. American Academy of Pediatrics.
Good morning, Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Stanford University, and Chair, Committee on Infectious Disease, American Academy of Pediatrics.
Good morning. American Academy of Pediatrics, Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Good morning, Marie-Michelle Léger, Director of Clinical Education, AAPA.
Good morning. American College Health Association.
Good morning, Sharon McMullen, Cornell University, and Dr. Tavi Chai, University of North Carolina at Chapel Hill for ACHA.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. All right, we'll come back. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine, Private Practice, Coral Springs, Florida, as well as Affiliated Associate Professor at Florida Atlantic University for American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Hey, Dr. Lee, I don't think Dr. Schmader's going to be here today.
Okay, thank you. American Health Insurance Plans.
This is Bob Gluckman, American Health Insurance Plans.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle for the American Immunization Registry Association.
Morning. American Medical Association.
I'm Sandra Freihofer, General Internist in Atlanta, Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle representing the ANA here.
Thank you. American Osteopathic Association.
Stan Grog, present. Good morning.
Good morning. American Pharmacists Association.
Good morning. This is Steve Foster representing the APHA.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIMS.
Thank you. Association for Prevention, Teaching, and Research.
Rex Zimmerman, University of Pittsburgh.
Thank you. Association of State and Territorial Health Officials. All right, we'll come back. Biotechnology Innovation Organization.
Good morning, Dr. Lee. Phyllis Arthur on behalf of BIO.
Good morning. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization. We'll return. Infectious Disease Society of America.
Carol Baker, Professor of Pediatric Infectious Disease,
University of Texas McGovern Medical School in Houston. Good morning.
Good morning. International Society for Travel Medicine.
Elizabeth Barnett, present.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACHO, present.
Morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, representing NAPNAP.
Morning. National Foundation for Infectious Diseases.
Good morning. William Schaffner for the NFID.
Good morning. National Medical Association.
Good morning. Tanya Rogo, present.
Good morning. Pediatric Infectious Diseases Society.
Good morning. Sean O'Leary, present.
Morning. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning, everyone. It's Amy Middleman for SAM.
Thank you. Society for Healthcare Epidemiology of America.
Good morning. It's Marcy Drees, Chief Infection Prevention Officer at Christiana Care, representing SHAE.
Thank you. I'm going to go back and just call on the three organizations I had missed to see if they are here. American College of Obstetricians and Gynecologists.
This is Dr. Eckert, and yes, I'm here. Thank you.
Thank you. Association of State and Territorial Health Officials. And Canadian National Advisory Committee on Immunization. Okay. Well, with that, I think we have quorum for sure, so we'll move on. During today's meeting, I will invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. If you wish to respond to a particular comment or question, please do your best to indicate this electronically with a raised hand and a thumbs up, and I will do my best to track this. We'll now move on to the first session for the morning on Tick-borne Encephalitis vaccine. Dr. Kathy Palin, chair of the work group, will provide an introduction and overview of today's session. Dr. Palin, the floor is yours.
Good morning. It's my pleasure to welcome everybody to the Tick-borne Encephalitis vaccine work group. Next slide, please.
Kathy, I have pushed. I'm just waiting for it to respond.
Okay, thank you. All right, for background, the Food and Drug Administration approved a tick-borne encephalitis vaccine known as Tickovax on August 13th, 2021. No tick-borne encephalitis vaccine has been previously licensed in the United States. And as such, there is no existing ACIP tick-borne encephalitis vaccine recommendation. The tick-borne encephalitis vaccine work group was formed in September 2020 to review use of TBE vaccine in U.S. adults and children traveling abroad. Next slide, please. I want to thank all the members of the TBE vaccine work group, the ACIP members, ACIP liaisons, the technical advisors, ex officio, and CDC participants, ACIP secretariat, and then a special thanks to Dr. Susan Hill, who's been coordinating and making all of this possible. Next slide, please. Okay, the terms of reference for the TBE vaccine work group are to review information on TBE, including its epidemiology, clinical presentation, diagnosis, treatment, and outcome, and to review data on infection risk and burdens for travelers and laboratory workers, to review data on vaccine safety, immunogenicity, and effectiveness, to provide evidence-based recommendation options for ACIP, to identify areas in need of further research for informing potential future vaccine recommendations, and to publish an ACIP recommendation in the MMWR. Next slide, please. Today, we're going to be focused on a summary of the immunogenicity and safety studies of TBE vaccine by Dr. Susan Hill, who will also then share the next steps for the TBE vaccine work group. Thank you. Oh, yes. All right. So as a reminder of the work group timeline, the vaccine was licensed TBE vaccine, Tickovax, was licensed in August 2021. Today, we will be reviewing the TBE vaccine immunogenicity and safety. That will allow us in October to present evidence to recommendations in October, and then be prepared to have a vote on vaccine recommendations in February before the next tick season. Next slide. And so thank you very much. And I turn it over to you, Dr. Hills.
Thank you very much, Dr. Palin, and good morning to everyone. At the October 2020 ACIP meeting, the manufacturer presented summarised information on development of a TBE vaccine. But today I want to present a more comprehensive overview of the vaccine's immunogenicity and safety. There have also been some changes since that time, so this presentation will provide updated information and I hope a helpful summary of the relevant data for ACIP members following the vaccine's approval last month by the FDA. And also prior to presentation of the ETR to ACIP members at the October meeting. Today I'm going to cover the vaccine and its administration, immunogenicity after the primary series and after a booster dose, safety data, vaccine effectiveness data, and information on the vaccines used in special populations. This slide shows the vaccine development history for TBE vaccine, and I'm presenting this because it's important to help in understanding the data I'm going to be discussing today. So an earlier formulation of a TBE vaccine was first licensed in Austria in 1976. Changes to that formulation over time have included removal of thimerosal and a transition in the origin of the production virus seed from mouse brain suspension to chick embryo fibroblast cells. The current adult formulation of the vaccine was licensed in Europe in 2001, and the pediatric formulation became available in 2003. Because of the manufacturing changes that have occurred, the TBE vaccine work group has focused on data for the current formulation of the vaccine, meaning the vaccine available since 2001. During the last 20 years, this vaccine has had extensive use in TBE endemic countries, with more than 75 million doses administered, about 2/3 of those in adults and 1/3 in children. The vaccine is currently marketed in about 30 countries, primarily in Europe. Vaccine is an inactivated whole virus vaccine based on the European subtype of TBE virus called the Nordelsal strain. It's produced on chick embryo fibroblast cells. The adjuvant is aluminum hydroxide. There is no preservative, and the stabilizer is human serum albumin. The other ingredients and substances used in manufacturing, which might be found in the final product, are listed in the last 2 rows of the table. Vaccine has an adult dose for persons aged 16 years and older, and a pediatric dose with half the antigen content for children and adolescents from 1 through 15 years of age. Vaccine is supplied in a pre-filled syringe and is administered intramuscularly. This slide shows the vaccination schedule with the primary series of 3 doses shown in yellow and the booster dose in green. The schedule for adults is in the top row and for children below. The only difference is that for adults, the first 2 doses are administered 14 days to 3 months apart, and for children, the first 2 doses are 1 month to 3 months apart. The 3rd dose of the primary series is given 5 to 12 months later, and a booster dose may be given at least 3 years after the primary series if ongoing exposure or re-exposure to TBE virus is expected. I'm going to begin the presentation of data with information on immunogenicity after vaccination. If Before I begin, I wanted to note that there are no vaccine efficacy trials because the low incidence of disease would make such trials infeasible. As a result, vaccine licensure and evidence for protection has been based on immunogenicity endpoints. TBE virus neutralising antibodies are believed to confer protection against disease, and a 50% neutralising antibody titer of 10 or higher is generally used in vaccine studies to indicate protection. However, no formal correlate of protection has been established, and there are no standardised reference reagents available. Key data on immunogenicity after the 3-dose primary series in adults came from initial and follow-up observational studies conducted in Poland among adults aged 16 to 64 years. In the initial study, the seropositivity rate at approximately 1 month after the final dose of the 3-dose primary series was 99% among the 416 adults in the study. In a follow-up study, the seropositivity rate at 3 years after the final dose, immediately prior to the booster dose, was 94%. This graph shows the geometric mean titers, or GMT, of neutralising antibodies at intervals after dose 3 of the primary series. The GMT showed a moderate decrease between 1 month after the primary series and 2 years after the primary series, but then remained relatively stable until 3 years. Key paediatric immunogenicity data after the primary series came from initial and follow-up observational studies conducted in several European countries among children and adolescents aged 1 to 15 years. In the initial study, the seropositivity rate at approximately 1 month after the final dose of the 3-dose primary series was 99% among the 360 subjects in the study. In a follow-up study, the seropositivity rate at 3 years after the final dose, immediately prior to the booster dose, was 98%. This graph shows the GMT of neutralising antibodies at intervals after dose 3 of the primary series for children in the age groups of 1 to 2 years, 3 to 6 years, and 7 to 15 years. Similar to the adult data, the GMT showed a moderate decrease between 1 month after the primary series and 2 years after the primary series, but then remained relatively stable until 3 years. The pattern was similar for children in all age groups. To summarise the data from these key studies on immunogenicity among adults and children, the study showed high seropositivity rates of 99% at 1 month after completion of the 3-dose primary series, and high seropositivity rates of at least 94% persisted through 3 years after the primary series or until immediately prior to the scheduled booster dose. However, there was a moderate decrease in GMT that occurred. It mainly occurred initially, with little change in GMT seen between years 2 and 3. I'm now going to present some key data on immunogenicity after the booster dose. Key data from adults on immunogenicity after a booster dose administered at 3 years after the final dose of the primary series came from further follow-up of individuals in the adult study I mentioned earlier. In this cohort of 232 adults, 100% were seropositive at 1 month after the booster dose. Seropositivity rates of at least 94% were maintained through 5 years after the booster dose, and by 10 years after the booster dose, seropositivity rates were still high at 85%. As you can see on this graph, there was a moderate decrease in the GMT within the first 2 years after the booster dose, but a relatively slow decline from 2 years to 10 years. Key paediatric immunogenicity data after a booster dose were from further follow-up among individuals in the paediatric study I described earlier. In this cohort of 172 children and adolescents, 100% were seropositive at 1 month after the booster dose, and by 10 years after the booster dose, there was still a high seropositivity rate of 90%. This graph shows the GMTs over time after the booster dose depicted for children in 4 age groups. Similar pattern was seen in all age groups with an initial moderate decrease followed by a slow decrease through 10 years. So to summarise the key data on immunogenicity after a booster dose among adults and children, the study showed high seropositivity rates of 100% at 1 month after a booster dose, and high rates of at least 85% persisted through 10 years after the booster dose. There was a moderate decrease in GMT that occurred within the immediate period after the booster dose, followed by a slow decrease through 10 years. I'll now present some key safety data for the vaccine. Key safety data for adults came from a study that included almost 3,000 adults aged 16 to 64 years. Overall, the rates for solicited adverse events within 3 days after dose 1 were 36% for local reactions, 14% for systemic reactions excluding fever, and less than 1% for fever. Percentage of subjects with an adverse event was highest after dose 1, so these can generally be considered the highest rates of adverse events after any dose. There were few severe adverse events. The rates of severe adverse events after dose 1, shown in the table on the right of the graph, was 0.1% for local reactions and 0.03% for systemic reactions. And there were no subjects with a severe fever higher than 40 degrees Celsius. The most common systemic reactions after dose 1 were fatigue, headache, and malaise, each occurring in 7% or fewer subjects. There were no serious adverse events considered vaccine-related by the study investigators. Key paediatric safety data came from a study that included 2,417 children and adolescents aged 1 to 15 years. Overall, the rates for solicited adverse events within 3 days after dose 1 were 25% for local reactions, 20% for systemic reactions excluding fever, and 10% for fever. Similarly, as for adults, the adverse events rates among children were higher after dose 1 than after subsequent doses. So again, these can generally be considered the highest rates after any dose. The rates of severe adverse events after dose 1 were 0.2% for local reactions and 0.1% or 3 children with severe systemic reactions. The severe systemic reactions for these children were generalised urticaria in 1, severe headache in 1, and arthralgia in 1. There were no subjects with a severe fever higher than 40 degrees Celsius. While the fever rate overall after dose 1 was 10%, fever rates were variable by age group, occurring at higher rates among younger children. Rates range from 36% among young children aged 1 to 2 years to 6% among older children and adolescents. However, most fevers were mild. Among the children in the 1 to 2 year age group, the age group most at risk for febrile convulsions, 2/3 of all fevers were lower than 38.5 degrees Celsius and none were higher than 40 degrees Celsius. In addition, fever rates were substantially lower after subsequent doses, with fever rates of 1 to 2% overall after doses 2 and 3 of the primary series. The most common solicited systemic reactions in children after dose 1 were headache, which was reported in 11% of subjects overall, restlessness reported in 9% of children aged 1 to 5 years, and fatigue in 6% of subjects aged 6 to 15 years. There were no serious adverse events considered vaccine-related by the study investigators. summarize the key data on safety among adults and children. After dose 1, solicited local adverse events were reported in 36% of adults and 25% of children and adolescents, and systemic adverse events in 14% of adults and 20% of children and adolescents. Fever rates were variable by age group, but were mainly mild, and no fever higher than 40 degrees Celsius was reported. Severe adverse events were uncommon. Rates of adverse events were highest after the first dose and substantially lower after subsequent vaccine doses. As I mentioned earlier, there are no vaccine efficacy studies for TBE vaccine, and there are also no field effectiveness studies for Pfizer's TBE vaccine alone. However, there is a vaccine effectiveness study from Austria that has some partially relevant data that I wanted to briefly mention. The assessment had some limitations because most, but not all, of the TBE vaccine used in Austria during the relevant period was Pfizer's TBE vaccine. It was estimated that about 90 to 95% of vaccine in use was Pfizer's TBE vaccine. And when TBE occurred in a vaccinated person, there was no information on which TBE vaccine the person had received. In addition, many vaccinated persons would have received the previous formulation rather than the current formulation of the Pfizer TBE vaccine. And finally, effectiveness was measured based on adherence to vaccination according to the recommended primary and booster vaccination schedule used in Austria, but not necessarily that for the US approved schedule, and not at a specific time point after vaccination. Despite these limitations, the data are useful to briefly review. During the period 2000 to 2006, the vaccine effectiveness estimate overall, which you can see in the bottom row of the table, was 99%. Vaccine effectiveness estimates by age group are listed in the rows above that and show that effectiveness was high in every age group, ranging from 96 to 99%. An updated vaccine effectiveness estimate without age-specific data covering the period 2018 to 2020 showed a similar overall vaccine effectiveness of 96%. I'm now going to present some brief information on disease and vaccination among special populations. For TBE disease, a limited number of case reports suggest pregnant women have a similar spectrum of illness to non-pregnant persons, and transplacental transmission of TBE virus has not been established. No studies have assessed the safety or immunogenicity of TBE vaccine in pregnancy. There are some limited safety data available from the manufacturer's safety database. This database is based on reports submitted by healthcare providers and others from other sources, so is more likely to capture data where an adverse event occurred than when vaccine was administered without the occurrence of an adverse event. However, it's also likely to capture only a small proportion of all occurrences of any event, whether an adverse event occurred or not. During the 45-year period from 1976 to 2020, when more than 150 million vaccine doses were distributed, there were 138 reports submitted to the manufacturer. 60 of them related to vaccination of a pregnant woman, where neither the mother nor infant experienced an adverse event. For 48, the mother remained healthy, but the infant outcome was unavailable. And for 30, there was an adverse event reported in the mother or infant, but there was no distinct pattern of adverse events seen in either the mothers or infants. In regards to breastfeeding women and TBE disease, 2 case reports indicate transmission of TBE virus from infected breastfeeding women to their infants. For one infant, the outcome was reportedly severe, and in the other, the infant was healthy. No studies have investigated the safety of TBE vaccination in lactating women. Limited data are again available from the manufacturer's safety database. And from 1976 to 2020, there were 25 reports of a breastfeeding woman being vaccinated where the manufacturer received a report on the event. In 11 of these reports, follow-up of the infant indicated there was no adverse event. In 8, the infant outcome was unknown. And in 6, there was an adverse event in the infant that included a fever in 3, a rash in 1, and gastrointestinal symptoms in 2 infants, one of whom was hospitalised for colic. For immunocompromised persons, TBE virus infection can result in severe illness, and these individuals have a higher risk of a fatal outcome. There are limited data on use of TBE vaccine in persons with altered immunocompetence, and in many of the available studies, either a previous formulation of the vaccine or a modified vaccination schedule was used. However, to summarise overall, immunogenicity results were variable, but typically showed a lower response in persons with altered immune status. And when an adequate response occurred, development of the response was often delayed. The available safety data suggests that this inactivated vaccine was well tolerated. In regards to TBE in older persons, it's well recognised that the incidence and severity of disease are highest in older persons. Most studies on TBE vaccination in older persons show there are high seropositivity rates after the primary series. For example, in one study, 99% of the 137 healthy elderly adults aged 70 years or older were seropositive at 1 month after completion of the primary series. There has been some concern expressed in publications about the duration of seropositivity over the longer term after the booster dose in elderly adults, particularly at 5 or more years after the booster dose. But data are very limited, with one study that followed up adults for 10 years after a booster dose having fewer than 10 subjects older than 60 years of age included in the data set. Adverse event rates in older persons have been shown to be comparable to those in younger persons. Finally, to complete this summary, I wanted to note that there are no data on co-administration of TBE vaccine with other vaccines. So to conclude, I will summarise a few key points from the topics I've presented today. There are good immunogenicity results following TBE vaccination, with high seropositivity rates within a few weeks of completion of the 3-dose primary series and following a booster dose administered at 3 years. Seropositivity rates are high in both adults and children. The vaccine also has an acceptable safety profile. It is relatively well tolerated with few severe, local or systemic reactions, and its safety profile is similar to many other inactivated vaccines. Among special populations, there are limited data, but some persons with altered immunocompetence might have a reduced immune response. No major safety issues have been identified among any of the special populations. There are some limitations of the immunogenicity data. As I mentioned earlier, in regards to interpretation of the seropositivity data, there is no formal immunologic correlate of protection. Secondly, the level of protection from this TBE vaccine based on a European subtype TBE virus for other subtypes of TBE virus transmitted in parts of Eastern Europe and endemic countries further east is unclear. Available data from human and animal studies and the genetic and antigenic similarity between the 3 main TBE virus subtypes suggests that there is likely cross-protection, but data are limited and vaccine effectiveness has not been demonstrated. So finally, to remind you of the work group timeline that Dr. Palin presented earlier, the TBE vaccine work group plans to present the evidence to recommendations framework to ACIP in October in anticipation of having ACIP vote on TBE vaccine recommendations at the February 2022 ACIP meeting prior to the next TBE virus transmission season. And finally, I want to acknowledge the excellent leadership of the work group chair, Dr. Catherine Palin, and our additional ACIP member, Dr. Wilbur Chen, and the hard work of all the TBE vaccine work group participants. Thank you very much.
Thank you, Dr. Hills. This presentation is now open for questions. Ms. Bata?
Thank you, and thank you for this well-articulated presentation. You mentioned that there was no data on co-administration of TBE with other vaccines, and yet we have children receiving this when they're younger. Do the countries that are providing this routinely give it with other routine vaccines? Do we have any idea?
I don't have that data at hand. I will say that because this is a travel vaccine, it's probably less likely and being recommended for 1 year of age and older. It's probably less likely to be administered for our US population, which will be travellers, in association with other routine vaccines. But as you know, that could be the case. There are no data on co-administration with other vaccines. No study data that I'm aware of. There are 2 studies that looked at that have considered vaccination in relation to other travel vaccines. When Japanese encephalitis vaccine was given after TBE vaccine, there seemed to be a stronger immune response. Conversely, with people with a history of yellow fever vaccination, when TBE vaccine was given after yellow fever vaccination, the response appeared to be a little bit lower. So they're the only data I have at hand. But thank you for the question.
Thank you, Dr. Hills.
Thank you. Ms. McNally?
Thank you. Can you comment on a rapid course of the vaccine, whether that's available for last-minute travelers, and also what the impact of that would be for children? Thank you.
So the rapid schedule, there is no specific rapid schedule defined. The period between the first 2 doses can be between 14 days and 3 months. So the briefest period would be 14 days for adults. That schedule is not approved for children. For children, the schedule is 1 to 3 months. So the minimum period between those first 2 doses is 1 month, with the 3rd dose administered 5 to 12 months later. I think I'm hearing what you may be asking, which is in relation to travellers who are travelling and may not have time to have a schedule over 6 months, with the 3 doses administered over 6 months. We do know that data after 2 doses suggests there is good immunogenicity after 2 doses of the vaccine, which seems to persist for several months. So, for example, in one study of adults who had 2 doses of vaccine, at 6 months after dose 2, 87% was still seropositive. However, the GMT the geometric mean titer does decrease over that period. And when they get the 3rd dose of the vaccine, the seropositivity rates rose to 99% and the GMT was boosted to 259. So in line with the FDA approval, we would recommend ideally that travellers do receive the 3 doses of the primary schedule before travel. But recognising that may not always be possible, we will have data on the immune response after 2 doses of the vaccine, and that will be included in the MMWR document that will be published. So healthcare providers have that available if they're looking at dealing with that situation. Thank you for the question.
Thank you.
Thank you. Dr. Daly?
Yeah, thanks much for that excellent presentation. Dr. Hills, given how high the seropositivity is prior to the booster dose, what's the scientific evidence that the booster dose is needed?
Thank you for the question. Yeah, so the booster dose can be given if it's at least 3 years after the primary series. The concern is primarily in relation to the geometric mean titers after the primary series, and we can see that they decrease over time. As I've mentioned several times, we don't have a correlate of protection that we are 100% sure is going to provide, seroprotection. And in that interval, we see the GMTs gradually decreasing and returning towards that correlate of protection that is typically used in studies. When the individuals get a booster at that 3-year time point, you see a substantial increase in their GMT, many-fold increase in their GMT, suggesting that it is boosting their immune response, and that is sort of reassuring for protection over the longer term.
Okay. Dr. Daly, anything else?
No, thanks much.
Okay. Dr. Rockwell.
Hi, thank you. Yes, I was wondering if we could, or if you might comment on slide number 25 that shows the GMTs at intervals after booster dose by age group. Because when I look at this and I see as the children and adolescents get older, their GMTs sort of drop in relationship to age, except for when it comes to the 1 to 2-year-olds who show a larger drop. I'm just curious about that.
Thank you. Yeah. I guess you're correct. There is that larger drop. I guess it was a small study, although the confidence intervals don't overlap. And I can't remember offhand how many were in that particular age group. I think the key information of importance is that the GMTs are all staying well above that GMT of 10, or the neutralizing antibody titer of 10 that we are using as indicative of protection over the for individuals. But I don't have any particular answer about that larger drop.
Thank you.
Thank you, Dr. Palin.
Yes, this is Kathy Palin. So thank you, Dr. Hills, for this presentation. I've just been looking up what's going on in Europe to answer the question for Ms. Bata. And if I understand it correctly, in Austria, it is they're the only country that routinely recommends the vaccine for children. And then Germany and Switzerland recommend it for persons in certain areas, children in certain areas. And in my review of the literature, I believe there's been no evidence that there's a problem with co-administration. Thank you.
Thank you, Dr. Palin. Thank you, Dr. Palin.
Thank you. Dr. Lair.
Thank you. I was wondering if the work group has thought about who they're going to recommend the vaccinations for. Is it just going to be travelers? I'm just curious if you've gone that far when you're thinking yet. Over.
The vaccine will be recommended among travelers, but also we have been looking at laboratory workers because there are a small number of laboratories in the United States that do work with TBE virus. So the work group is discussing our recommendations for US travelers and for laboratory workers, and we will be presenting our draft recommendations to ACIP in October.
To follow up, for some vaccinations, it's a certain amount of time in country. And so, like for Japanese encephalitis, you have to be in the area for a certain amount of time. Is that going to be part of the recommendation, do you think?
I won't preempt. Our recommendation to work group is still discussing that, and we'll be continuing to discuss that within the next few weeks before the October ACIP meeting. I wasn't also sure if your question related to whether there would be any benefit for the US population for this vaccination. We do have a tick-transmitted virus in the United States called Powassan virus, but the available data do not suggest that the TBE vaccine would provide any cross-protection against Powassan virus. So we will be focusing on travellers and laboratory workers. And when the work group has finalised our discussions and have some draft recommendations, we will be presenting them to ACIP so ACIP members can comment on what we have prepared.
Thank you very much.
Thank you. Dr. Hills, I have one question for you and then one general comment. Going back to what my colleague asked earlier about optimal time intervals, for the laboratory workers, the schedule as indicated makes sense to maximize the protection. It seems to me challenging to assume that somebody would complete a primary series before a trip, unless that was a very well-organized trip, well in advance of when they were planning to go. And oftentimes people who come in for travel vaccines are doing it just prior to leaving. What would you, or will there be clinical considerations around if somebody only gets the first 2 doses, whether or not to complete the series after they return, for example, or what will you recommend? And then if they decide to go again, would the series have to be restarted if they did not complete the primary series?
Yeah, so thank you for that question. There are data that suggests that if there is delayed administration of the 3rd dose, that there is still a good immune response. So that would be, we will be including information in the MMWR about that particular issue. To some extent, it's going to be an individual decision. There could be a variety of settings. So, for example, if a traveller or a person moving abroad is going to live, the vaccine is readily available in Europe. So there would be an option to complete the series once they have moved overseas. If a traveller is travelling just once and, is undertaking an activity that might expose them to ticks, but it's a one-off, those sort of considerations, but doesn't ever intend to go back to a country, that would be a decision for them to make. But what we will be doing will be sort of providing that information in the MMWR so healthcare providers can discuss that information with their travellers and consider the individual scenarios.
Thank you. I can ask my question after Dr. Sanchez. Dr. Sanchez, go ahead.
Thank you, Dr. Hills. Excellent presentation, informative. I just had a question, and you may have mentioned this, but there's protection. I think isn't it like over 90% protection after 2 doses, which would be 2 weeks apart, with respect to the schedule? and travel and just thinking what others have mentioned about incomplete scheduling.
Yes, so that's correct. So after 2 doses, there is a high seropositivity rate, and the GMT is high. In that interval between, that 14-day schedule is approved for adults. For children, it's 0 and 1 month, so 1 month apart. In that interval between the second dose and then the third dose given 5 to 12 months later, there is good seropositivity maintained. And you were right that at 6 months after dose 2, the seropositivity rate is 87%, close to 90%. However, the GMT does decrease. And so the GMT, as I said, is decreasing during that time. So the third dose then, will, if they are, for example, intending to travel again the following year and undertake activities again that are going to expose them to tick bites, then the third dose will clearly very strongly boost their GMT. I might ask if I can have slide 76. Thank you. So just to provide a little more data on this issue. So there was a study, and this is also thinking about the sort of the range of age groups that we're vaccinating. So this was a study that compared immune response in 2 age strata of younger and older persons, so 16 to 49 years and 50 to 65 years. And this slide shows the geometric mean titers at various time points after vaccination by age group. And in the interval between 3 weeks and 3 months after the second dose, which you can see there in the table, the GMT falls, as you can see, and then you can see that very strong boost when the third dose is given. So ideally, the 3-dose series should be completed prior to departure. But as I said, we will ensure that those data are available, understanding and very, very clearly hearing from ACIP that there will be a concern with trying to complete the 3-dose primary series prior to travel for most travellers.
Thank you, Dr. Hills. I just had one final comment, which is, and it's not specific just to this vaccine, but that we continue to need both clinical trial data as well as post-market effectiveness and safety data in some of these populations that you articulated. So specifically immunocompromised populations, older adults, and then pregnancy, and then the impact on pregnancy and the infants. I'm hoping that perhaps at the next meeting or in the interim, if it's possible to just capture some more information about the pregnancy and infant adverse events. I think that would be really helpful, recognizing the benefits during pregnancy for those women. Just because I do think perhaps thinking about pregnancy safety systematically, it would be extremely helpful for us to think about what is common in pregnancies versus what's biologically plausible and related to the timing of vaccination, particularly for infant outcomes. But I think that holds for many of our vaccines on the table. So thank you, Dr. Hills. Are there any other questions that our members or liaisons have?
Dr. Lee, if I could just respond to that question.
Sure.
Thank you very much for making that comment, and I will make efforts to get additional data. I did reach out to the European, so the EMA, the European FDA equivalent, European CDC, our colleagues there, colleagues in Austria, various colleagues last year to try and get data. And unfortunately, as we have all been, they have been overwhelmed by COVID. But I will definitely make additional efforts to get some data, because I'm sure, given their extensive use of the vaccine, and as I mentioned, with 75 million doses administered during the last 20 years, there must be some additional helpful data. So I will attempt to get those and present them to ACIP at the next meeting.
Thank you, Dr. Hills. And Dr. Sanchez.
Thank you. I just want, in addition, and to add to your comment, Grace, with the breastfeeding mothers, because it's an inactivated whole virus vaccine. And so it really shouldn't pose a risk during breastfeeding. So I really think that it should also be included there so that we can also recommend it.
Thank you.
Yes, and the work group has discussed language for lactating women. I think that's what you're saying. So we did, and as you've rightly said, we did review the ACIP General Best Practice Guidelines for Immunisation, which, as you said, say with two exceptions, which are smallpox and yellow fever, neither inactivated nor live virus vaccines administered to lactating women affect the safety or breastfeeding of women or their infants. So yes, we will definitely try to obtain additional information, but given the general guidelines, we are planning the language we have proposed is that breastfeeding is not a contraindication or precaution to vaccination.
Great, thank you.
Thank you. And I see no more hands raised after Dr. Sanchez. So I believe we can now plan to close this session. Given that we are ending a little bit early and we do have a packed agenda today all the way to the very end of the day, I'm going to ask that we convene reconvene again at 11:15 a.m. EST, so 15 after the hour. Thanks, everyone.